It's my privilege to be the track chair of the Gynecological Cancers track this year at ESMO, and I'm an ESMO Executive Board member. So in the next few minutes, we will cover the standard of care and progress so far in PARP inhibitors for ovarian cancer. The disclosure slide is here. So just to put this into context, ovarian cancer is among one of the most common cancers affecting women. And the travesty is it has one of the most highest mortality rates. So it's the 8th commonest cancer affecting women. And what you can see here, that although there are many more women suffering from breast cancer, when you look at the incidence compared to the mortality, there are higher rates of death from ovarian cancer compared to the other more common women's cancers. But there has been progress in advanced ovarian cancer treatments, and in particular, significant advances with targeted therapy, which is what I'm going to focus on today. So bevacizumab and PARP inhibitors do provide new hope for ovarian cancer patients. And in order to illustrate this today for you, I thought it would be helpful to look at the EMA approval since the first targeted therapy in ovarian cancer, so going back over a 7-year period from 2011 to 2018. The first targeted therapy to gain approval was bevacizumab, and this drug blocks a molecule called VEGF, which attacks blood vessels which cancers need to thrive. And the indication in 2011 was in the frontline treatment for women with advanced ovarian cancer in combination with chemotherapy, and then also taken as a maintenance therapy afterwards by itself. And then following this, shortly after, in the next few years, bevacizumab gained indications and approvals for the treatment of women with relapsed or recurrent disease. The next real wave of breakthroughs of approvals come with PARP inhibitors. And as you will see here, there are 3 PARP inhibitors, olaparib, niraparib, and rucaparib, which have EMA approval. The first PARP inhibitor to be approved was olaparib capsules, and that was back in 2014, and it really changed the landscape of treatment. And this is for women with Braca mutated ovarian cancer in the relapse setting as a maintenance therapy. And as you will see, so far, all the indications for PARP inhibitors are in the relapse setting, so not in the front line. And back in 2014, it really fueled and highlighted the importance, which we currently still have very much so at the forefront, the importance and need for access to Braca mutation testing for women with ovarian cancer. So niraparib gained approval in 2017, and the difference here, the new breakthrough, was access of PARP inhibitors for women regardless of Braca mutation status, and then a year later, that was the indication for olaparib as well. And finally, rucaparib has approval as treatment for women with Braca-mutated ovarian cancer as opposed to a maintenance therapy. So as I've shown you, the standard of care has really changed with the PARP inhibitors changing the landscape. PARP inhibitors are effective and approved in women with recurrent ovarian cancer. That has returned more than 6 months after completing the backbone of chemotherapy, which is platinum-based chemotherapy for women with ovarian cancer. So how do these work quickly? Well, PARP inhibitors work by blocking an enzyme called Parp, which is heavily involved in the repair of DNA in cancer cells. So with these drugs, DNA in cancer cells can't be repaired, and that leads to cancer cell death. And we know that these drugs are most effective in women with known problems with DNA repair, so BRCA gene mutations. And Angelina Jolie raised the profile of the relevance of BRCA mutations as she is a BRCA1 carrier, and unfortunately her mother died at the age of 56 with ovarian cancer. So 1 in 6 of the most common ovarian cancer types, that's high-grade serous ovarian cancer, 1 in 6 women have a BRCA mutation, so this is highly relevant. In relapse, PARP inhibitors significantly delay the time until cancer returns or worsens and the time to the next treatment, which is often chemotherapy. So I've mentioned 3 PARP inhibitors that have approval, and in BRCA-mutated patients, the overall results are very similar for all the PARP inhibitors. There is a significant and substantial reduction in the risk of progression by between 70 and 75%, and that is very meaningful for women with ovarian cancer. To put it into context with regards to time, if we look to median, that means averages progression-free survival, for example, with olaparib, for women that were in the placebo arm in relapsed ovarian cancer that didn't get olaparib, olaparib, the median time was around 5 months, and for women with olaparib, that was extended the time before progression to over 19 months. So Parp inhibitors are only available, as I've discussed, for women whose cancers has come back. So what about treatment for newly diagnosed ovarian cancer? That includes women with Braca mutations. Well, it remains surgery and platinum-based chemotherapy, so carboplatin and paclitaxel is the standard of care, and in many countries, bevacizumab is also part of standard of care. But despite these treatments, the majority of women, the time before progression after standard of care is between 10 and 20 months. And what we do know is 70% of women relapse within 3 years of first-line treatment. The 5-year survival rate for advanced ovarian cancer for stage 3 patients is only 20%. And for those with stage 4 disease, that drops to 5%. So I hope I've shown you that there is an urgent need to improve treatments for women with advanced ovarian cancer. And with that, I'll hand over to our next speaker. Thank you.